A very good morning to all of you. I am Suchismita Dey, Scientist Assistant Director at ChanRe Rheumatology and Immunology Center and Research. It is our privilege to invite all of you for the 13th ChanRe Update 2015. The management of autoimmune diseases, including rheumatoid arthritis, has changed significantly in the past 2 decades. Such changes already existing or new are yet to reach the doorsteps of the patients. The best example is the prescription of practice of disease-modifying anti-rheumatic drugs or DMARDS. Early treatment inventions using disease-specific anti-rheumatic drugs is considered as the cornerstone in management of rheumatoid arthritis and also to prevent or reduce progression of joint destruction and synovitis. However, it is necessary to rationalize the treatment approach as well as the protocol to facilitate the wider adoption of these drugs in daily clinical practices. There are many recommendations invented as assisting clinicians in making appropriate decisions on DMARD therapy. Even at the smallest estimate of 0.3% incidence or 1% prevalence, RA affects substantial proportion of the patients. But a general estimate suggests that only 40 to 50% of the RA patients are exposed to DMARDS and majority of them are subjected to underdosing of DMARDS. Initial ChanRe update has deliberated on DMARDS. As the years are rolled down, there is an accumulation of new scientific data which has promoted us to have a relook on them. This scientific session of ChanRe Update 2015 is mainly focused on a relook on various treatment aspects of commonly used DMARDS and the challenging clinical scenarios confronting during the therapy. Is biologics the answer when there is the failure with DMARDS will also be addressed. In this update, forenoon session will discuss the concept of treatment to target how to manage RA patients and the basics of DMARDS. The post-late session will focus on lab parameters used for monitoring DMARD therapy and how to interpret them. The meeting will be concluded with workshop on joint count, which is a key component in measuring the disease activity in RA. Once again, I would like to take an opportunity to welcome all of you for the 13th ChanRe Update 2015. And I hope you will enjoy the session. Now we will begin with our first session. The first session is sponsored by Johnson & Johnson. For this session, I would like to request our esteemed chairpersons, Dr. Nagaraj S. and Dr. Chetna to come over the stage. Dr. Nagaraj is presently a consultant rheumatologist at Sparsh Hospital, Bangalore. He is also a visiting rheumatologist at ChanRe Center. He did his post-graduation in pediatrics from CSI Howard Memorial Hospital, Mysore, and subspecialty training in rheumatology from Hinduja Hospital, Bombay. He has 8 published papers and 34 published abstracts in peer-reviewed journals. Dr. Chetna is presently a consultant rheumatologist at Apollo Hospital, Bangalore. She has done specialty certificate examination of rheumatology from Royal College of Physicians, UK. She has worked in tertiary center and district hospital in various parts of UK, and she is expert in managing wide range of rheumatological conditions. To introduce the concept of this session, I would like to gracefully welcome our chairpersons and would request them to take the lead.
Thank you. First of all, good morning everybody and welcome to ChanRe Update 2015. The first speaker for the day is Dr. Chandrashekara, who I don't think really needs an introduction. But briefly, Dr. Chandrashekara graduated MBBS in the year 1988. And then did his MD in General Medicine from Mysore Medical College, Mysore University in 1992, followed by DNB in the year 1992, and DM in Clinical Immunology at SGPGI, Lucknow in 1996. So he's currently Professor, Medical Director, and Consultant Rheumatologist. Well, he's the founder of ChanRe Institute of Immunology, Rheumatology, and Research. Since the end of 2002, he is an ex-professor and HOD of the Department of Rheumatology and Immunology at MS Ramaya Institute of Medical Sciences. He's a research consultant at Vivekananda Yoga Kendra, Jigni, Bangalore. He's an editor and founder of Arthritis News, published IARET Trust till date from 1999. He is also an advisory board member of JK Science Scientific Journal, published from Srinagar, editorial board member, Orthopedics Today. Managing Director and Managing Trustee of Immunology, Arthritis Research and Education Trust since 2000 till to date. He's consultant at Mallige Medical Center since 1997, and he goes as an examiner for DM Rheumatology in Madras Medical College, Chennai. He's also an editorial board member of Journal of Indian Rheumatology Association. Can we please welcome Dr. Chandrashekara on stage?
Good morning. At the outset, I welcome all of you. And today it's a great honor for the entire update. I could see my professor, who has taught me the medicine, to be a part of here. Professor Gauri Shankar, I welcome you, sir. And before I go into the lectures on DMARDS, and all of us have now know that we need to prescribe DMARDS. And we are in a mid of the road, how much to prescribe, how should I prescribe, and when should I prescribe. Before getting into that, I thought let me spend my first 5-10 minutes of my lecture, how did this concept of disease-modifying anti-rheumatic drug really came into force. And we need to remember, Nile was flowing before it was called Nile. In a sense, it took all of us to know that there exists a drug called disease-modifying anti-rheumatic drug late in the course of our understanding, but we could see from the history, right at 1928, first time Forestiers tried injectable gold in rheumatoid arthritis. Whatever could be the concept with which he started with, because he thought it would be useful in rheumatoid arthritis because it was considered at that time, because it was an era of microbiology, because where everything is thought to be an infective etiology, he thought tuberculosis could be the reason for rheumatoid arthritis. And previous to him, there was a study which showed that injectable gold, both in vitro as well as in vivo, can inhibit mycobacterial growth. So that resulted in the first time study, in a landmark study, where he could show that injectable gold can do a lot to the patient suffering from rheumatoid arthritis. First time, 1976, is the article where the drug name called disease-modifying drugs of anti-rheumatoid was introduced, right in 1976. There's one very interesting article from where I could get this. He has done a real search through the literature to figure out from the history where exactly the disease-modifying anti-rheumatic drug came in. The first of the article where the drug disease-modifying drugs in rheumatoid arthritis was introduced was in 1976. And then the first time in 90, DMARD acronym came into existence. We were totally in a confusion what to call it, why to call this name. There were so many different names which came to this nomenclature. We were using what we call as slow-acting anti-rheumatic drug, second-line anti-rheumatic drugs, and so on and so forth. There was thorough confusion overall over a period of time. And also at that point of time, since we were fighting with the infective diseases as a predominant problem that we were facing, the whole medical faculties were concerned about the malignancy, cardiovascular disease, which were ready to capture those diseases at that point of time. It was considered that rheumatoid arthritis is a benign disease, nothing big thing happens, and you need not worry so much, treat him symptomatically, things should work better for them. With that concept till 1990, and this is the one which you see if you read through the textbooks in 90s and even up to 95, 96, if you want to treat a rheumatoid arthritis, treat it in a pyramidal fashion. To start with, try with good physiotherapy, occupational therapy, non-steroidal anti-inflammatory drug to keep his pain under control in a palliative force. Then think of adding a little bit of steroids, not helping. Then you think about disease-modifying anti-rheumatic drug like injectable gold, methotrexate, and the last tip, you can try out any of those cytotoxic drugs. period of time we started understanding, late towards 90s, we started thinking that if we start disease modifying anti-rheumatic drug, there going to be a big change. What really made us to bring forth the disease modifying anti-rheumatic drug, till now what we used to call it as a second line DMARDS, into a first line drug, is the observation over a period of time. If you introduce disease modifying anti-rheumatic drug early in the course of the disease, the patient do very well even in long term over a period of time if you watch a patient who is not treated or not interfered with disease modifying anti-rheumatic drug. In addition to that, many studies started showing it that there is a significant reduction in the expectancy of life of the patients of rheumatoid arthritis, like more or less close to diabetes mellitus, cardiovascular disease, tuberculosis and lymphomas. More of these cases started indicating that if you intervene rheumatoid arthritis early in the course of the disease, you can stretch the life expectancy. You can certainly increase the life expectancy. More just than life expectancy, you can give them a quality of life. So this made us to revert the entire pyramids, and the DMARDS, which used to be in a second line place, moved into the first line place. Other revolutionary changes which happened was, we started understanding combining drugs is one another art in which you can treat the patients. We realized if you combine 4 or 3 drugs in anti-tuberculosis, outcome is good than using a single drug. And we were also worried at that time of resistance, the drug resistance also you can overcome. In oncology, combination drugs started making a very good outcome. It also suggested that yes. And we also started realizing when we started working on mechanism of rheumatoid arthritis, it's not one cell which participate in the entire process of rheumatoid arthritis. There are multiple cells which are participating in that. So this prompted us to work with combinations. Use methotrexate plus sulfasalazine plus one more drug. Use multiple combination that could work. But what was blocking us in thinking process is the safety first. It's a benign disease, unlike an oncology. It's a benign disease, unlike a tuberculosis where the death is not imminent. Patient can live for 10-15 years with pains and aches, with deforming joints, but why should we interfere with a toxic drug where we can cause an immediate mortality? So the question, think safe, was a question which prevented us in using combination in early 90s and late 2000s. But at that point, I can tell you what is we consider it as safe. I mean, these are the pictures which I picked up from definition with reference to vaccine. We think of so much on vaccines. We know very clearly vaccine do cause its death, 1 out of 1 million, 1 out of 10,000 or 1 out of 15,000. The question of safety is, we started to redefine, work on the safety, and we started figuring it out that the safety is always with reference to the relativity of a position or a problem that exists at that point of time. If I look at oncology treatment, we don't bother about flushing them with 3 or 4 toxic drugs because we know the end outcome, if I don't handle him like that, is a death. So are we really going to expose the patient of rheumatoid arthritis to such a high risk? If I give methotrexate 25 milligram, if I give sulfasalazine in addition to that, if I add one more drug to that, the amount of risk I am exposing to him, is it worthwhile for the quality of life which I am going to give him for next 10 to 15 years? These studies clearly started showing it off that the risk that you are going to expose these patients with the disease modifying anti-rheumatic drug is worth it to the quality of life. You are going to figure it out. So finally stands with this particular statement: trust the DMARDS because you are willing to accept the risk, not just because we talk about it, it's a safe drug. It is certainly safe, but if you want, you can go through the literatures that are available, amount of incidence, adverse event that's going to happen, compare with the steroids which can otherwise give a similar benefit. If you look into these data and these information, it clearly suggests that the outcome that you are going to get with the introduction of disease modifying anti-rheumatic drug is far superior to what the risk you are otherwise exposing these set of patients. In addition to that, the lot of studies published in early 90s and late 90s clearly stamped out saying that the incidence of adverse event is more or less similar to monotherapy. since it is safe, you can use the combination of disease-modifying anti-rheumatic drugs too. When we were toggling between these, there was a twist to the way we are trying to manage the rheumatoid arthritis. We started trying to work out how exactly we should measure, what we should do when we are trying to treat a rheumatoid arthritis with disease-modifying anti-rheumatic drugs. Because in any treatment when we want to introduce, we need to know what is the end point where I should stop. If I start with 10 milligram of methotrexate, what's the point where I should stop this particular drug? One point is, of course, the safety. Above a point, patients start developing toxicity, I should stop it. But with reference to the response to the disease, what's a point where I can stop it? Which is the point where I should chew? So there, we started working on identifying the measures. You can see the first attempt was done as late as 1956, but there was a wide gap. I tell you the reason is, we were thoroughly confused whether we should really aggressively treat or not. And from 90, many newer measures came. Finally, we landed up in using DAS score, which was described in 95. We have CDAI, SDAI, and ACR, which are very commonly used in measuring the rheumatoid arthritis. This added to the concept which we started working on, disease-modifying anti-rheumatic drugs. Fundamentally, I think you might have seen this slide in my 3-year before update, where I was trying to explain why we should set a target when we are measuring or treating the chronic diseases. When we are treating a chronic disease, we need to know at a point when we are treating what we are likely to achieve down the lane in next 10 years. This is what we call as clinical glide path in any chronic disease, which suggests that if I achieve a point when we are treating at the current time, or am I going to achieve what I expect down the lane in 10 years? The best example, most of the physicians who are handling it, we know very clearly, if I have a tight glycated hemoglobin control around 7.5 to 6.5, definitely the number of complications are much lesser. We started getting a note with reference to rheumatoid arthritis from various studies. If you keep disease activity score under check between 2.6 and below, you have a very good outcome. You can reduce the deformities, his quality of life good, and his coronary vascular disease is lesser, life expectancy improves. So we now know what we should do at this point of time. This all put us into a rethinking that we can treat and handle that. At the same time, revolution took in the other aspect of understanding the immunobiology of rheumatoid arthritis. That led to the discovery of a group of drugs, what we call biologics. The biggest advantage of biologics compared to the old German aircraft bomber to the current precise bomber is the drugs precisely handles 1 or 2 protein molecules which are responsible for immunopathogenesis of the rheumatoid arthritis. That made us to suppress or bring down in a very precise manner the immunosuppressive or immunomodulatory effect which we can do with reference to rheumatoid arthritis. So we had now a potential drugs to treat rheumatoid arthritis. We also over a period of time understood how a combination etc. can manage and what we should measure when we are trying to treat the rheumatoid arthritis and so on. At the same time, many studies clearly indicated if you treat early in the course of rheumatoid arthritis, you are going to make a big difference to the patients of rheumatoid arthritis, what we call as critical window opportunities. If you interfere at this point of time, you are able to give a drug-free remission is quite a good percentage of patients. So this understanding made us to appreciate how and well we should manage rheumatoid arthritis. This is the learning course what we went through over a period of time. I happened to enter the field of rheumatology when the real revolution was going on, because I entered the field of rheumatology in 94, and that's a point where a major turn of events were happening and we could really witness these changes happening. We started realizing, yes, DMARDS work, then we realized combination works, we know immune interventions are beneficial, we can target cytokine, early intervention makes a difference. We can now start thinking about remission. That means there is a major drift from what we were thinking as a palliative treatment, treat the symptoms, bring down the symptoms, to a point where we can start thinking about, we can induce a state of remission where the patient can get rid of the disease process. But yet we have to achieve the target. We are still at the target, but we now know at least what we should look into, and is it a possible target. Those understanding we have come into. With this background in the mind, with so many available disease-modifying anti-rheumatic drugs, we need a guide path. We need to know when to start, what to start, how much to start. This is what we talk about as protocol. The first of the guidelines came from ACR in 1996. That's where we started thinking about how we should introduce disease-modifying anti-rheumatic drugs. There it made precise point to say that as soon as you diagnose it as a rheumatoid arthritis, start treating rheumatoid arthritis. It was revised in 2002, where the choices of leflunomide entered the options because leflunomide came into existence at that point of time. Biologics, still we were under process of clinical trials and understanding whether they are useful, and we were also thinking what to do with reference to. So we just introduced at this point of time, the ACR guidelines came us to explain how and when and how to introduce these drugs. And in 2008, there are much more evidences. We thought working about a possible clinical remission and a target to treat came into existence. At the same time, there was a development of a new ACR-EULAR criteria which made us to diagnose rheumatoid arthritis at least 6 to 8 months earlier than what we used to diagnose using the older 1987 criteria. So in a sense, there was a change in criteria which became a requirement because the older 1987 criteria was able to make us to diagnose only late in the course of the disease. That's why when we started realizing early intervention makes a difference. That's a point of time the world across, the rheumatologists started thinking across that there should be a criteria where I can pick up the disease. That's a point when the ACR criteria, ACR-EULAR criteria of early diagnosis came in. At the same time, we started learning the target, and there came the recommendation to treat to target, and subsequently there are various recommendations which started recognizing that we need to target a specific point up to which we need to alter, escalate, change the intervention that we are doing, so that end game we achieve this target, we will be able to get what exactly we are looking for the patient. So what exactly the points which we normally work when we start working with reference to the protocol of disease modifying anti-rheumatic drugs? We have 4 ways of working it. Number 1, you can use a single drug, what we otherwise call monotherapy, where you can keep switching. In a sense, what I mean is, use methotrexate, not helpful, stop it, change to leflunomide, not useful, stop it, change to one more drug like either biologics or etc. This is what we call as monotherapy and switching the disease modifying anti-rheumatic drugs. We are not really very happy about it. I'll tell you the point where we can still try with this. And next we go into what is called as combination therapies. As I said, we think it's quite safe to use a combination therapies. There we have 3 ways of working it. One is step up, start with a single drug, beneficial, not beneficial, add one more disease modifying anti-rheumatic drugs, not helpful in the next 6 to 8 weeks, add the 3rd disease modifying anti-rheumatic drugs. Then we have another entity what's called step down. Start with a full force and then slowly bring it down once you have achieved the target. And sawtooth is where to keep the target in place, increase the dose, decrease the dose. This is what we typically do with reference to anti-diabetic drugs. We keep altering, increasing the insulin dose as and when required depending on the glucose control. But in rheumatoid, it's little difficult because any change takes a lot of time for it to be accepted or projected into the DAS course. So that being the case, sawtooth don't sound very well for any of the rheumatologists who have tried or worked with, because the moment you stop, you don't know whether when he is going to come back with the disease. And that's why most of us either we go into the step up or step down approach. Then other things we have is combining with biologics and conventional disease modifying anti-rheumatic drugs. We are seriously considering the 5th option of combining biologics, but still it's a theoretical thing. We are worried about the expected consequences, and steroid associated regime where steroid is either added in the beginning and then withdrawn or added in between. So certainly we have a 5 different way of managing and manipulating this group of disease modifying anti-rheumatic drugs. The best of the protocols that you get is from ACR 2008. In ACR 2008 protocol, it utilizes few of the factor in stratifying the patients. If the patient is in the earlier than 6 months, and if the patient has no features of poor prognosis, preferably can use lower end disease modifying anti-rheumatic drug like hydroxychloroquine and minocyclines. If the patient has the poor prognostic features like high titers of rheumatoid factor, very high disease activity, or family history of other possible deformities, use a drug preferably leflunomide, methotrexate or sulfasalazine, use monotherapies. If the patient has moderate to high disease activity with poor prognosis, use combination disease modifying anti-rheumatic drug. Without, preferably you start with monotherapy, go for step-up therapies. But there are a lot of dispute with reference to this, whether we should use every patient with the same approach or we should go with a differential approach. We need a lot of work to be done with reference to these fields. We are not very sure whether this is a best of the protocol. It's been questioned, re-questioned, many studies are going on with reference to this. There are a lot of controversies existing with reference to that, but however, the current protocol which is being approved or used is the one where we look into this when the disease is less than 6 months. When the disease is between 6 months to 24 months, there the patients without the poor prognosis with low disease activity, still you can use monotherapy, and when it is with, you preferably use 3 drug combinations. On the other hand, there with poor prognosis, preferably use 3 drugs, but the latest addition is in this group of patients, it preferably use a biologics along with one of the disease modifying anti-rheumatic drug. That's a latest revision where they have tried. In this point, one can add biologics along with these disease modifying anti-rheumatic drugs. When the disease is more than 24 months, here you can see even if there is a low moderate disease activity, without, you preferably use higher group of drugs in combinations, and with features of bad prognosis, you need to use this along with small to moderate dose of corticosteroids. So in a sense, there is a sort of stratification which you need to work out with the patient, personalize it to the patient depending on the poor prognostic factors, presence of the disease activity, and also presence of the duration of the illness. Why these factors are taken is the duration, as the longer the duration of illness, more or less likely he is going to respond. And there are enough studies which clearly suggest that higher the disease activity at presentation, less likely he is going to respond. So in a sense, when the patient has a possibility of poor response to the drugs, go with a higher push with reference to disease modifying anti-rheumatic. This is the fundamental on which it works. The question comes is whether it is step up or step down. Advantage of step up is when we are not very sure whether patient respond or not, better play safe. Start with less number of drugs, gradually go on escalating, and you also know very well whether patient tolerates your drug or not. You start with 10 milligram, call him back after 4-6 weeks, tolerating, no response, increase to 15. Instead of pushing 25 milligram at start, patient walking to you in the next second, third day with an adverse event. So there are 2 ways to work on it. But the disadvantage you have is there is a gradual reduction in the disease process. It takes time for the disease process to come down, patient to be symptomatically better with reference to disease. We are not very sure whether this quick reduction is required. But there are few studies which says if you can bring down the disease activity within the first 3 months, you are more likely to have these patients maintained in low disease activity. But there is a contradiction in this observation. The contradiction interpretation in this observation is these are the group of patients who are very responsive to the disease-modifying anti-rheumatic drug. That is why their long-term outcome is also good. It is not because the drug you have used has induced the remission. So there is a controversy with reference to this, whether it is the rapid reduction is responsible for an outcome or the disease itself was in such a character that the reduction was possible, hence he behaved like that. In a sense, it is the behavior of the disease rather than the process being implied by going with step-up therapies. Till this resolution comes, we are now confused on the priority of basis. You can use either step-up or a step-down regimen. So in a nutshell, when there is an active RA, act instantly, start using a main target of remission, adopt the therapy according to the disease activity, whatever the best which can bring a low disease activity or a remission, continue the therapy till the state goes for a sustained remission. Can we withdraw? There are studies now which are working that when we should withdraw, what are the characteristics on which we can withdraw. Till such time comes, current recommendation is continue till the patient continues and you would like to continue the drug. In the next group where you are not able to get the things, look into at least a minimum low disease activity, adopt a therapy which is safe and patient can tolerate and continue to have a sustained low disease activities. So in conclusion, we have moved from earlier 90s concept of disease modifying anti-rheumatic drug as a second choice to the drug of choice in rheumatoid arthritis. As soon as you make a diagnosis of rheumatoid, start the patient on disease modifying anti-rheumatic drug. Need carefully choose the disease modifying anti-rheumatic drug based on the patient characteristic. Choice depends on the disease characters as well as on the patient safety. The main end point in the whole of the protocol is to achieve a disease activity score less than 2.6, which is the ideal, but this is what we need to achieve. So the journey of disease modifying anti-rheumatic drug, as you could see, those started as early as 1976, took a long time to pick the pace. It really took off a pace in 90, and now it has made things more clear that we need to handle this drug with disease modifying anti-rheumatic drugs. And in the next few hours we will be going through few of the very important disease modifying anti-rheumatic drugs which needs to be treated and managed. And also in the end of the day, the next post-lunch sessions, we have workshops where and how one can work with the monitoring of the rheumatoid arthritis drugs adverse events, as well as on the workshop on measuring and how to handle when we are handling the rheumatoid arthritis patients. Thank you very much for patience here.
Any questions from the audience?
It gives me immense pleasure to join you. I bow down to the dignitaries on the dais and off the dais, and also to the honorable speaker. I am always fond of sitting in the time machine and going back in retrospect. This arthritis has been observed since even before, I should say, 3000 BC or 2000. So many people were there in the sense. There are a list of pioneers who worked on this particular thing, coined the name and this meaning, terminologies, etc., and various drugs. So to start with, they started using oils and something, so many things, application, acupuncture, so many things are there. And they made out aspirin to present day drugs, so many things have been coming up. The most important thing I wanted to say, the Nobel Prize was given to George Hilton Heggie and Gertruson for discovering allopurinol in this particular case. At the same time, I cannot forget Yalla Pargada Subbarao and also Ravinder Main, who also contributed for this rheumatology. And I cannot forget Dr. Chandrashekara and Dharmanand also. I wish that you should also be in the list for Nobel Prize. I bless you that you should become one of the topmost leaders and whatever it may be. Now, is it possible to make an early diagnosis? Rheumatoid anticipate, something like Angelina Jolie, she had, mother had carcinoma, but the genetics of studies or something like that. Is it possible to make out who are going to get this rheumatoid arthritis in this particular patient? Is it possible or not genetically?
No, I mean, I just read it in the newspaper. I couldn't get hands on the original paper of that. I think they have described one of the new antibodies against one protein actually. They have said that if you can identify it, you can predict the development of rheumatoid arthritis with 90% accuracy. I read the original paper, I can't speak or talk on anything. It's a paper clip in Times of India which had come, which I could see through. I think it has come only 2-3 days back.
Yesterday's paper or no?
Yes, it came a couple of days back actually.
Yeah, exactly. Well, that's what I was also, and just that it is very difficult to tongue twister name is. They were able to make it out, protein, tenacin, and then something, there's something to do with this one is responsible. 15 years earlier than the diagnosis, that's what I was I noted in the paper. God bless you. Thank you very much. Very enlightened.